Okay, so I think we're ready to start the next workshop session. My name is Sheena Barlumi. I use pronouns she, her, hers. I'm an able-bodied cisgender female, and I'm a third-year medical student at the University of Michigan Medical School. I am an Iranian American born in Rochester Hills, Michigan, and today I'm wearing a black shirt with a tan background. And I want to welcome you to a very exciting workshop. It is the Disabusing Disability Workshop. Enough about me, though. I will just be your moderator, kind of fielding questions back and forth between our speakers and the chat room. So if we can just do a quick introduction of the people who will be leading this workshop. I think we can start with Dr. O, who you've heard from today.
I will ask all of my fellow panelists to show their cameras first before I start. So as you all have heard, I'm Dr. O. I use he, him, his pronouns. I am a disabled, young to middle-aged Black man of Nigerian origin, cisgender, heterosexual, living in Michigan. I'm an assistant professor of family medicine, physical medicine and rehab and urology, and I'm the interim director of services for students with disabilities and the director of adaptive sports and fitness at the University of Michigan. And now I will hand it over first to Miss Elise Zomlack.
Hello, I am Elise Sanlac. I use the pronouns she, her, hers. I am an able-bodied cisgender female. I'm a Caucasian American born in Ypsilanti, Michigan. I'm wearing a dark purple blouse with a plain tan background, and I'm a third-year medical student here at the University of Michigan.
Next up, we'll go to Miss Kate Panzer.
Hi, everyone. My name is Kate Panzer. I use the pronoun she, her, hers. I am an able-bodied cisgender female. I am an American, part Filipino, born just outside of Philadelphia, Pennsylvania. And today I'm wearing a black and white striped shirt with wood panel background. And I'm a first-year medical student here at the University of Michigan.
Thank you, Kate. And then how about Mr. Eric Rebesniks?
Thank you, Dr. Okanlami. My name is Eric Rebesniks. I use the pronouns he, him, his. I'm an able-bodied cisgender male, and I am of Canadian and Latvian descent, born in Toronto, Ontario, Canada. So pleasure to be joining all of you. My role is the project manager of the Adaptive Sports and Fitness program at the University of Michigan, and I'm sitting here with a navy blue top with an Adaptive Sports and Fitness logo. To my top right is an Adaptive Sports and Fitness logo, and in behind me is our Adaptive Sports and Fitness program at the Varsity Tennis Center at the University of Michigan.
Thank you, Eric. And then we'll go to Miss Rachel Hargis.
Hello, my name is Rachel Hargis. My pronouns are she, her, hers. I'm a white wheeled woman wearing a white shirt and black blazer, sitting in a room painted gray with pictures hanging on a wall over my left shoulder. And I work as a coordinator in the University of Michigan Services for Students with Disabilities office.
And last but not least, Miss Jordan Funk.
Hi, everyone. My name is Jordan Funk. I use pronouns she, her, hers. I'm a disabled white female from Ohio. I'm wearing a black blazer with the Diversity in Medicine blue and yellow kind of polka dotted background. And I am also Disability Services Coordinator at the University of Michigan.
Thank you to the amazing team. And I will say that, look, I forgot the rules that we try to abide by, and I did not even mention that I'm a brown-skinned man with dark rim glasses, a wooden bow tie, a Diversity in Medicine maize and blue background with a white coat on. Now, disabusing disability is the talk that we're going to present to you all today. And I tell people that hear me speak that I don't like giving talks. Now, anyone that knows me will chuckle because everyone knows I love talking. And I said, it's not that I don't like talking. I don't like giving talks. I like starting conversations. So I really hope for today to be a conversation amongst all of us here on the panel and you in the audience as well about disability, because disability is something that is ubiquitous. We're here talking about diversity in medicine, and too often disability is missing from the conversation of what diversity truly means. And as we were mentioning in some of the earlier conversations and panels and workshops, we need to recognize that we are all better together. And too often what we do is we silo and separate to then make people feel as though they are specific in their own struggles and not recognizing that it's because of a lack of understanding of the diversity that ties us all together as humans, that we need to then recognize how it is important to see that just because we may not have a certain lived experience doesn't mean that there are things that are not happening in life because we don't know it. So I tell everyone that my slides are merely a suggestion, and that if we are able to then have a conversation that then carries us beyond any of the things that we're saying, I don't care about the slides, and I want you all to put things in the chat to then bring things up that you want to mention so that we can then engage you in conversation. So I start with this slide. I usually use this slide because conversations about diversity, equity, and inclusion are often difficult for people. People don't know how to then have these uncomfortable conversations, and this slide has been used in many different ways to talk about what equality is and what equity is. So to describe it, this is an image that has 3 individuals. There's 2 panes of this slide. On one side, it says the word equality. The 3 individuals are each on one box trying to look over a fence at a game. The tallest individual is able to see the game, the medium height individual is still able to see the game, and the shortest individual cannot see the game. Now, the next slide on this, the next image has equity under it. And with equity, the tallest individual can still see over the fence with no boxes. The shortest individual has 2 boxes and can see, and that medium height individual has 1 box and they can still see. Now, I use this slide because this is what I like people to think of when we're having conversations about diversity, equity, and inclusion, is that we need to understand the needs of people on both sides of this fence. Because when you show this slide, people that are woke, that know diversity work will say, why is the fence there in the first place? We need to have the image that says justice, where the fence is taken down. We should not be putting up barriers. But when we show this slide, I've had individuals that play softball or baseball and say, the fence is not there to keep people out. The fence is actually there to keep things in. And so we didn't realize that people felt as though we were excluding them by the things that we were doing. We just realized that we needed to know how to hit a home run over the fence. We didn't want the ball to go out into the street. And so I think that if we recognize that there are fences there for certain reasons, but if we have conversations with people on both sides of that fence, we can understand what it is that people want and need. But the important point here is that sometimes people on either side of the fence do not want the people on the other side of the fence to have access. And so if we recognize that not everybody wants the same thing, and that not everybody thinks that equity and equality are things that we should even be discussing, it will allow us to then focus our efforts on the individuals that just may not know that they are keeping people out by having the fence up. Because there are absolutely people that want to keep fences up to keep people out. Because when I show this slide, people will say in the chat after I presented it, someone said, why don't those insert racial expletive here buy tickets like everyone else and watch the game from the inside? I'll say it again. They say, why don't those insert racial expletive here buy tickets like everyone else and watch the game from the inside? Some people look at this slide and see that this is people trying to take from one another. Some people look at this slide and think that the people outside that are dark-skinned in this image are stealing or are not doing enough or are just trying to get something that they are not due. Now, that is the reason why this is an uncomfortable conversation to have, especially when the reality of our lives looks more like this image that now has a third pane where the tallest individual has many, many more boxes than they need. We show this because the resources are not often allocated in a way that everybody gets what it is that they need to have access to something that we think is the same. Some people will say, why did I have to give up my box in that first image to that smaller person? They will look at this third image and say, that individual dug themselves that hole and we should not have to give up our resources for that person. The conversation comes around, why should people have the same access to things if people have different life experiences, different ability to do things, that should not be fair because fairness is not what we strive for. So these are uncomfortable conversations, but when we just talk about moving boxes around, it allows people to then show their emotions and how they perceive these things, because this image was just an image, but this last image is what's going to tie it together to our conversation today. Because when we have a conversation with people on both sides of this fence, we then look at this image, which is an attempt to demonstrate there is more diversity in this image than in the first few. You could make an assumption based on gender norms that I do not ascribe to, but that I want to then say based on what this slide is trying to show. This image can say there might be more genders that are being represented in this one. Some people assume that the first slides were just all men. You could also say that that first slide did not have different races because everyone seemed to be brown skin, and in this one, there are different races represented. I tell people all the time that even with the reallocation of boxes, if you gave me a box as a wheelchair user, it would not improve my access in any way. So sometimes you need to take that wood and then create something different, which is a ramp to allow people to have access. And then the last part of this is looking at the rainbow in the top right corner. Now we also identify LGBTQ. This slide is just meant to cause people to think and have conversations to say, if we want everyone to be valued, if we want everyone to have equity in terms of the access that they're provided, we need to then have a conversation that represents everyone. We need to recognize that the resources needed for everyone may be different. And that if we start to acknowledge that and talk to people, we will find what resources they need and allow them to get the things that they need to have access. Now, I talk about my story not because I'm the first or the best or the only, but because my story is the only story that I know personally. No one is going to have the exact same lived experience as anyone else. And therefore, we are not here to then judge others' experiences, but we're merely here to recognize that the things that we experience are valid to us and should be important to you because of the shared humanity we have. I lived my life as an academic All-American athlete at Stanford, almost trained for the Olympics, turned medical student here at Michigan, orthopedic surgery resident at Yale, before I had a spinal cord injury in my third year. These types of things, jumping into the sand, jumping after I graduated from medical school, having a wonderful family to support me, I thought that those things were what made me able. I thought that those things gave value to my life. I was judged by the way I could jump into the sand. I was judged by how high I could score on an exam. And those were the metrics that were success for me until this. Until I had a spinal cord injury that made me paralyzed from my chest down with minimal use of my upper extremities. And at that point, the question was, what is my worth? If disability means inability, I'm now unable to do all the things that I could do before. I'm now unable to be a doctor. I'm unable to have a voice. I'm unable to be seen as the person that people saw me as before. Now, I tell people I've lived my entire life as a Black man, believe it or not, but I felt discrimination more prominently post-disability than I ever had as a Black man. Because my Deerfield, Stanford, Michigan, Yale, Notre Dame degrees seemed to shield me in some way from the belief that I wasn't qualified. However, after having an injury and then now learning life, as I call it, on the other side of the stethoscope, I have been exposed to a world where our life and our world is not accessible for disability. And I will say I'm even lucky that my disability is one that is visible because many people understand trying to build a ramp to give someone access. But people don't understand the other ways that our world is very, very ableist and does not provide the accessibility we all need. So here in medicine, I was blessed with the opportunity to be given certain resources. So these are the boxes and the ramps that were built for me. This is a standing frame wheelchair, which has allowed me to get back into doing procedures the way I did before. I'm looking at a microscope here on the OB rotation in my family medicine residency, looking for ferning. Those of you that don't know, look that up later. And the slide next to that, I'm in my chair. I was about to access someone's carotid artery to then do a catheterization in the cath lab. And so these things made it such that I then had the access and the resources to demonstrate my ability to be successful. That ability did not change at all because I was disabled. And anyone that either lives life their entire life with disability or comes into that world later on is no less of an individual and is no less qualified to have access to all the same things. So with that, that is the reason that I've invited this team here today, because the first step for this is talking about how we provide these access needs. How is it that we're going to provide individuals with what they actually need to be successful? So Ms. Jordan Funk and Ms. Rachel Hargis in the Office of Services for Students with Disabilities are going to talk to you a bit more about what they do in that work and how we can demonstrate that the individual with the disability is not the problem or the barrier. It is the institution and the structures in place that make our world inaccessible that are the things that we need to change to then make sure that everyone has equitable access. Take it away, Rachel and Jordan.
So, Disability is the largest minority population in the United States. It spans all identity groups and is the only minority group you can join at any time in your lifespan, and the chances of you becoming disabled increases the longer you live. While disability is an integral part of diversity, it is often overlooked as some disabled individuals need accommodations for equitable access. In the past 48 years, 3 civil rights laws have been passed to ensure equitable access for disabled individuals. The first is the Rehabilitation Act of 1973, specifically the 504 the Americans with Disabilities Act of 1990, and the Americans with Disabilities Amendments Act of 2008, which had the most impact on accommodations, as it expanded the definition of disability to a person who has a physical or mental impairment that substantially limits one or more major life activities. This includes people who have a record of such impairment, even if they do not currently have a disability. It also includes individuals who do not have a disability, but are regarded as having a disability, which subsequently allowed more people to become protected under the ADA and subsequently request workplace and educational accommodations.
And to jump into the role of disability services and educational accommodations from there, disability services work is guided very heavily by the laws that Rachel mentioned. In practice, it's important to engage in an interactive process with students to identify barriers they experience in the educational and clinical settings and what is a reasonable accommodation that may remove those barriers. In recent years, there's been a large uptake, and I know a lot of faculty have noticed that too, in students requesting and receiving accommodations. And there's a lot of reasons for that, but some of them include there's more students with disabilities attending college. Students are covered, students have been covered by the ADA since birth at this point. The folks that we're seeing now have received accommodations in the K through 12 setting. They're used to receiving those accommodations. And another one is new technology allowing access to students with sensory and physical disabilities. One example I like to bring up, there's a Supreme Court case from 1972, Southeastern Community College versus Davis. It was about a deaf nursing student who was denied entry into the program. The program required students to use a traditional stethoscope to hear heartbeat, and the deaf student could not do that. The court ruled in favor of the school at that point in time and said that they did not have to admit the student. They did note, however, that the future technological advances may enhance opportunities where this ruling would become unreasonable and discriminatory. So now, fast forward to today, we're seeing technical standards that say a requirement is to detect instead of to hear a heartbeat, with the knowledge that students can use, a visual stethoscope who may be deaf, or an amplified stethoscope for those that are hard of hearing. So there's a lot of examples of these improvements in access, but technology is one that has really allowed us to further explore disability-related barriers and, what is a true essential component to learning. So with that, I could go on for a long time, but next up, we're going to hear from Kate about medical students for disability and health advocacy.
Thank you so much, Jordan. So again, my name is Kate. I'm a first-year medical student at the University of Michigan. And this year, I worked with a couple of classmates to start a new group called Medical Students for Disability, Health, and Advocacy. And really, we wanted to start this group because we recognized that there was a lack of space for medical students to come together and discuss different topics and issues around disability in medicine, but also to support and advocate for medical students with disability and chronic illness. So those are the two components of our group that we're really focusing on. We're really excited to get this group started. We have our first event coming up next week where we have a panel discussion of different faculty describing their experiences with going through medical training and clinical practice with a disability or a chronic illness. So really excited for that. And then just to give you an idea of what's going on across the country related to this, there are several institutions that either have a student organization focused on disability in medicine or are currently working to form one. And so that's really exciting to see the progress there. And there are also groups that are focused on connecting these institutions and these groups together. So for example, there's a group that was started by students at Stanford University called Medical Students with Disability and Chronic Illness, or MSDCI National. And so that's another group that just started recently this year. And so just really excited to see what we're able to do together and accomplish as we connect with other student groups. So if you're interested in this at all, I'm happy to talk with any students, faculty, really anyone about this. I'll share my email in the chat. And then also I encourage you, if you're from a different institution, to look and try to find if there are student groups that are focused on this at your institution as well. But thank you so much. And then next, I'd like to pass it on to Elise to discuss the disability health elective.
Hi, so I'm Elise, and I am in charge of the Disability Health Elective here at the University of Michigan. This was a project that was originally proposed by a graduating medical student who is now Dr. William Zhu, and passed on to me. And what this elective is it is a 2-week elective for clinical medical students, so people who have finished their clerkships. And it's a hybrid elective, so we have online components of the elective where we have lectures and didactics that are pre-recorded, as well as some live discussions with faculty members. And then the clinical component of this elective involves going to different clinics that specialize or have a high population of different individuals with disabilities. And so we cover a pretty broad spectrum, anywhere from physical disabilities, sensory disabilities, and then cognitive and mental health disabilities. And then the last part of this elective is this community experiences, which I think is the best part of our elective. Students get to go and participate and talk to and interview some individuals in different programs in our community. We work with the Special Olympics College here at the university. We also work with the Ann Arbor Center for Independent Living, as well as a couple different organizations that we're trying to get in contact with. And so this really provides students an opportunity to learn more firsthand what it's like, the challenges that their patients with disabilities are facing, as well as the special needs that, needs to go into the care for these individuals. And so I can also put my email in the chat for anyone from different schools that are interested in talking more about this. There are some great programs at a couple different schools that are working on this curriculum, which has been shown to really be something that students miss throughout their education. So I'm happy to talk about this with anyone. And next I will be introducing Eric, who is going to talk to us about adaptive sports and fitness.
Thank you, Elise. Now, why sports? And why is this a part of the conversation? And, it's a question that I often reflect on, and, and I think a lot of people reflect on, and especially given recent social events that have occurred over the past year. And I think sport is just an extremely powerful tool, especially because it's so rooted culturally in our daily lives, and really impacts a lot of the things that we do, whether it's individual transformation or whether it's the social groups that you're then connected to, the way that it could empower a certain sect of society, and how it can really elevate new potentials and new horizons, and ultimately at the societal level in terms of what it does for policy change, and what it does in terms of inspiring a greater collective. But at the same time, sport isn't always equitable when it's delivered, and how it's accessed, in the people that it benefits. And even if you do have access, it doesn't always benefit people in an equitable fashion. Think about the first slide that Dr. O showed us. And it's not just about the people taking in the experience from the sidelines, but it's also the people on the pitch, the people in the stands, the people broadcasting. And overall, sport touches so many people in so many different ways, but is not equitably enjoyed by all the time. And with that, I want to really force everyone to recall a time in their daily lives where they felt they didn't belong. And I think that the intersectionality of this workshop, of this conference, and of all the speakers that we've seen today is I think everybody can draw upon a time where they felt they didn't belong. Now, also think about a time that you did belong. Think about a time where you were given the resources and the social support and the physical resources to succeed. And think about that moment in the sun where you felt lifted, where you felt inspired, where you felt transformed. And I think that's really the purpose of why the Adaptive Sports and Fitness program exists. We know that there's an inequity of access when it comes to adaptive sports or sports for people with physical disabilities. So what are we going to do then to address that inequity so that everybody has that opportunity to achieve, whether it's personal success at a physical, psychological, mental, or social level, whether it's changing attitudes and behaviors within schools and institutions and programs, whether it's driving greater policy change. I think there's a lot of things that can be done through sport as a means to generating greater inclusion. Now, as such, what you see on the screen here are the 4 key pillars to the Adaptive Sports and Fitness program. But what you don't see are all the people, all the resources, all of the key individuals and groups and community members and organizations that it takes to really create a seamless and integrated and inclusive system. When they say it takes a village, it's really true. And that's what we're trying to do with the Adaptive Sports and Fitness program, is identify, how do we go beyond our barriers and the confines of the institution and engage with community members, engage with primary health providers, engage with schools, engage with all levels of the community to ensure that everybody has an equitable opportunity to access and to participate and enjoy the benefits of sport participation. We have our Adaptive Sports Student Interest Group, which aims at generating an increase in awareness and knowledge among students and faculty at the University of Michigan about the Adaptive Sports and Fitness program and the movement of adaptive sports. We have our Adaptive Sport and Inclusive Recreation Initiative, which aims at embedding adaptive sport and reforming the educational policy within the state of Michigan by adding adaptive sport as part of the physical education curriculum that then all students go through at a K-12 level. Too often students with physical disabilities are left sitting on the sidelines, and that can be related to any domain, any field, and quite frankly, any minority as well. So what we're really trying to do as a program is not just deliver sport programs, but really understand the different antecedents and different factors from all aspects of society that contribute to equity of access. We also have an adaptive fitness aspect of our program, which addresses the need that people with physical disabilities need to go to the gym just as much as able-bodied individuals. And lastly, we have our adaptive sports side. And I want to draw upon a little story and how it relates to the field of medicine and how it relates to the Diversity in Medicine conference. We recently had an athlete join the program who was not completely aware of and had knowledge of about his disability and how that then connected him to an adaptive sports world and society and community. It often participated in able-bodied systems or systems that benefited able-bodied individuals and wasn't given the equitable opportunity to really thrive in a situation that accommodated his disability. Now, this individual was very successful in the sports that they competed in and in the activities that they pursued. But often what I point to is that when you see minority groups and individuals that succeed, And we often point to them and shed some light on them and point to the successful minority individuals that exist in the current system. Well, it's not because of the system. The system did not get them there. Those are just extremely talented individuals with determination and a really good local support system. So how do we then make a system that is more supportive? And how do we build a system that gets more people, that equitable opportunity to succeed? Now, just recently through the medical system, people started engaging in conversations with this student about adaptive sports, about the opportunities for people with physical disabilities to get the resources they need. They are now on their way to train at a national level and perhaps even compete at the Paralympic level. Why? Because all it took was a few conversations in the doctor's office, in the clinic, to just direct this person to the resources that exist. But at the same time, the resources also need to exist. The point that I'm trying to make is that collectively, there needs to be an integrated support system so that people know about, so that there are resources and there are opportunities for people to participate. But at the same time, those key influencers and key individuals, whether they're teachers, whether they're parents, professors, your friends, your family, whether they're primary healthcare providers, whether it's your doctor or your dietitian, that they're referring you to the opportunities within your community, to have that social support, to set you up for success. That's what the Adaptive Sports and Fitness program aims to do.
So I want to call all of our team back up onto the screen at this time. I know that we are running up to the end of our time, and Dr. Blackstock has already joined us and will be speaking soon, but I want to answer one question that was asked in the chat about when to disclose. Now, I think the issue of disclosing when one has a disability is something that, unfortunately, this system has made it such that that question is even needed. Because if disability weren't seen as a four-letter word, if disability weren't seen as something that was a negative, I'm sorry, I live next to an airport, so you're hearing my planes. If disability were not something that were so stigmatized and marginalized, and if people weren't thought that they were not as qualified if they were disabled, then the notion of disclosure would not be such an issue. Now, the reality of this is that we have to hold these truths at the same time. That one, I want people to be able to have a system that supports them and views them as equal to everyone else, even if their disability, visible, invisible, apparent, not apparent, is something that they have. Simultaneously, we need to then allow people to then recognize that disclosure is not something that everyone is going to be comfortable doing, and therefore our system needs to be put in place to then make sure that access is a given. Access should be something that all have, such that accommodations aren't even necessary in many situations. Because one of the things that I say is that everyone can use the ramp, but not everyone can use the stairs. And so therefore, what each of these individuals has been talking about is building ramps to access for all, whether that's the amount of time you have on an exam, whether that's giving someone time to stim during a class, whether that's making sure that we introduce ourselves with a visual description, have CART services present, an ASL interpreter, and make sure that no matter what the disability is, they do not feel like a burden by getting the access that all of us just enjoy as a given. I tell people that I do not blame you for not understanding this, because prior to my own disability, I did not recognize how inaccessible things were. But what I also say is that the past may not be your fault, but the future will be. So if you've learned something today, if you've heard of things that you did not know existed, if you've discovered barriers or fences or walls that were put up that keep people out, then what can you do to try to create that access? Whether it's a student group, an adaptive sports program, an elective, or providing the educational accommodations that everyone deserves. Each of us can work within our sphere of influence to then impact change. Each of us can enact change with the roles that we have, no matter where in the system you feel you fall. Because as someone said earlier, and I'm going to say often, it is not that people don't have voices that we need to speak for them. It is that those voices haven't been heard and are not listened to. So each one of you can use that voice to then provide access for everyone. Thanks, guys. I think with that, I will allow, I don't know if Adure is in here yet. I will turn it over to Adure to introduce our final speaker of the conference. Here you are, Ms. Nwaba.
Hi, everyone. We'll give you guys, thanks, Dr. O, that was great. We'll give you guys another 1 to 2 minutes, 1 minute just to breathe real quick, catch your breath, and then we'll come back.